You're watching this video probably because you're planning to do oral medication and insemination. And I'm going to talk about what it is, why we do it, and what are various risks and other issues you have to think about as you go about the process. So first of all, what is it? Oral medication insemination, a woman is taking pills to increase the number of eggs that are being generated, and then insemination where you wash the sperm, purify it, and put it directly in the uterus to increase the chances that sperm and egg find each other. The typical flow for this is after testing, because you don't want to go through this if the tubes are blocked, or if the tubes are blocked, you're trying to power through them, there are lower chances, but you want to be informed of that. But why we do this is typically we can accelerate fertility by achieving in 1 month what many people would in 6 months to 2 years of trying naturally, depending on how things are done. And what you do is you're trying to get 2 to 3 eggs in a given month, because if you're getting 1 egg, well, the woman was already generating 1 egg a month. Or if they're anovulatory, that would be a time where you would go from 0 eggs to 1, and it wouldn't necessarily be a bad thing. But again, if you have very irregular cycles, you want to make sure that's from having too many eggs that get in each other's way and you just want 1 egg, relative to ovarian failure, because that has very different implications. And then also, again, for insemination, you're also getting a free semen analysis, and that adds a lot of value, and you want to make sure that the numbers are where you think they are, because if people can be having sex at home for years, if there's no sperm to find the egg, that makes it very hard. So these are things that are very powerful for revving up fertility, and we can often see 30-40% of women getting pregnant over a 3-month period if they have the right circumstances. However, that again boils down to testing beforehand to make sure that the right building blocks are there. For how we go about it typically, we end up giving a woman, again, often letrozole. I don't like clomiphene. It seems to turn everyone into the devil. All the hot flashes and their risk for multiples, and it can thin out the lining, and a lot of issues that come with it. We tend to lean more towards letrozole for things. Not that it's perfect, but again, relative to the alternatives where you use injectable gonadotropins, which are really expensive, often we want to start with letrozole for things. If we are doing this, we do an ultrasound and we say, okay, we've got 1 egg that's kind of wimpy, we don't want to proceed, but 2 eggs or 3 eggs, that's good. If a woman is in her later 30s, that's often where 4 eggs have lower risk relative to someone being in their 20s, because a lot of the eggs are chromosomally abnormal in the later 30s. And so if you have a lot of abnormal eggs, you need more in order to find a good one. But again, we also want to combine that with insemination, because again, if you're having a 50-fold amplification for how many sperm find the egg, there's a greater chance that there's a normal, healthy one that successfully gets there. And so again, this is something that greatly accelerates fertility, but it has to be for the right people. And you can talk to us individually about, okay, where are my chances for what I'm doing? The way it plays out, again, ultrasound, roughly if you're on 5 milligrams or 2 pills a day, usually that will be day 12 of the cycle. 7.5 milligrams, usually more day 10. The earlier, the longer the dose, and the higher the dose, usually the earlier you have to scan and the more eggs that are being recruited. That then tells us, okay, here's the day for sperm and egg to find each other, and usually 36 hours prior to insemination, you will give yourself an HCG trigger shot. That is something that mimics the LH surge and makes it so that when we put the sperm back, they're sitting and waiting, ready for the egg to release, and shortly after, when the egg drops, so to speak, the sperm can readily find it. So this is really important. And also an advantage of this is we can get a free semen analysis with the insemination that gives us information so that we can be confident about where the sperm are when we try to do things. And by the way, with every ultrasound, we are also talking about, if the cycle were not to work, how would we do it differently? Because the single best time to learn from the cycle is when you do that evaluation. We're hoping you're pregnant and that's for a future child after the pregnancy with the current round. And so it's not pessimistic in doing so. It's simply saying, how can we do better and learn from current circumstances? In terms of things that people want to think about as you go about this, you want to be looking at the ultrasound and saying, how many eggs are here? And we will see this black fluid that is surrounding the egg, and if the fluid is relatively small and you're under 10 millimeters, we are not thinking that egg is likely to do anything. But if you see them 15, 16, 17, and more, and especially in the 20 to 23 millimeter range, those are eggs that are likely to release and to be found when you do the by the sperm when the trigger occurs. And sometimes we have to give a few more days of growth for that to happen. In terms of other things, as people go about the insemination is a lot like a pap smear in terms of the setup. Speculum is placed, we end up introducing a small catheter into the uterus, and then the catheter has the plunger depressed, so to speak, and then the sperm are introduced directly into the uterus, bypassing the cervix, and that goes a really long way. And again, that's back to, I keep emphasizing that number, the 20 to 50-fold increase in sperm finding the egg when you do it that way. And by the way, we have a lot of partners who want to depress the plunger, and some say not in a million years, and others say absolutely. It's interesting for a lot of lesbian couples where they're saying they can get their partner pregnant. It's kind of a cool thing for them, but I would say anyone who wants to do that, we will support you, providing it lines up readily. If we think that you would change the odds by lining it up or depressing things or something where, again, we don't feel we are as confident and we want to make sure things get where they need to be, ultimately the number one thing is getting people pregnant, and so we will adjust. But again, if we can have social niceties, we want that as well. And once we've done that, we usually have people lie back for 10 minutes. There's no difference between 10 minutes and 2 hours for pregnancy rates. And so as soon as you've lain back for that 10 minutes, that's where people are often driving home, and they can sit up. They don't have to have their feet up on the dash or anything crazy. Everyone wants to test as quickly as possible, but remember, with the HCG trigger shot, that's the same hormone as in a pregnancy test, and so consequently, doing that test a day or two after the insemination, it'll be positive even if you weren't pregnant. It was just the shot wearing off. And usually we say it needs about 2 weeks to fully wear off, but a lot of people cheat. They test early, they get this faint line, and they're not sure, is it the shot wearing off? Is it real? Is it a miscarriage? Drives them crazy. So I usually say to wait the 2 weeks. And if the period comes, obviously that's unfortunate and we can dive straight back into another cycle. But if not, and you do the pregnancy test and it's positive, we're going to be cheering and then following up that. Now, the next thing that people ask about, what are the risks to this? Infection is incredibly rare, but if you have abnormal discharge or fever or pain that persists after doing an insemination, obviously let us know. As with all things, if anything's concerning, let us know. We can't fix what we don't know about. Similarly, for other things we watch for is really, you don't see much for uterine perforation risk or bleeding associated with insemination. What we also watch for really relates to the conditions of pregnancy. Anything that can happen with a regular pregnancy can happen with insemination. Not getting pregnant, getting too pregnant with multiples, ectopic pregnancy, miscarriage, birth defects, all the types of things inherent to that really can happen with any mode of trying to conceive. And again, if you want individualized calculations or odds for these things, we're happy to address those with you one-on-one. But these are important things to think about. And I always joke, also anything that can happen, it includes a teenager who talks back to you or a 3-year-old who draws on the walls. Again, it is humbling to get pregnant, but the inherent things to pregnancy happen with inseminations and any mode of conception. The other things that we talk about for really doing insemination is, I think, the emotional toll. When you have that 2-week wait, it drives you crazy. And then one of the best things you can do is just really get active in other things. And that is build your relationship as a couple. Do other things, but don't just sit there waiting for the result as much as you can. Now, that's easier said than done, but I just think the more you can look at this as a process where you're saying, okay, we're going to give it a few rounds of trying and not put all our eggs in one basket, it's a horrible pun, but really on a given month, that makes a lot of difference. When I see people where they have 15 to 20% chances per month, again, that 1 in 6, you take a 6-sided die, you roll it, get a 6, you're pregnant, 1 through 5, you're not, there's an 85% chance in a month that it won't work. That's not failure of the technique, that's only as well as it works. And you just have to say, but if we give it 3 months, for many couples, there's a 30-40% chance they will be successful from it. So you have to give it a reasonable chance before then we say, well, this isn't playing out. Maybe we need to explore additional opportunities to conceive through something high-tech like in vitro fertilization. There are also many couples that can go on and do 3 more rounds, for example, of oral medication and insemination. This should be individualized. Talk with us, find out what's right for you, and we're open to supporting you. We have a lot of people who are on the journey there, also getting to a point where they're saying, I'm done. I need either to recover and take a break, and that's important to talk about because for many people, if they have a lot of time, they can take a break. But if it's really hard to rev up the ovaries and then you create momentum, you may want to continue that momentum. Or if people are getting older or running low on eggs, time may matter more, and you want to figure out where that biologic clock is ticking. So communication on that is really important. Ultimately, with all of this, we just want you to be successful and safe and happy. And so if you have any questions on any of this, let us know. We'll answer as much as we can. But good luck, and I can't wait to do a pregnancy ultrasound for you and see that beautiful heartbeat and the legs kicking and all those other good things. It's amazing how much can happen, but some of these things do take time, and hopefully your time is soon. Ask us anything. Talk to you later. Good luck.